It's my pleasure, although as of Friday I didn't think I have a speaker for this spot, but I got an email from Dr. Zoutman, like, we'll meet on Monday and talk about what your needs. I thought I was moderator. I didn't think I was doing a presentation. What presentation? It's okay, we got it all worked out. He's here. He finished his presentation at the airport. Dr. Zoutman is professor in the Division of Medical Microbiology and Infectious Disease at Queen's University. He's a professor of pathology and molecular medicine at the Community Health and Epidemiology of Medicine, also at Queen's University. Dr. Zoutman recently assumed the role of Chief of Staff at Quinte Healthcare Corporation. A primary focus of his investigative work has been the use of modern quality improvement methods in the prevention and control of healthcare-associated infections, as well as new sterilization and disinfection methods. Dr. Zoutman is past physician director for CHICA Canada. He is also an honorary member of CHICA Canada. And he has his black belt in Lean and Six Sigma for healthcare. As I said, after finalizing his presentation at the airport, Dr. Zoutman will be discussing the pros and cons of alternative disinfection technologies for room decontamination. Welcome, Dr. Zoutman.
That's what airports are for. I'd like to thank the Scientific Committee of CHICA Canada and the organizers of this pre-conference day in Virox for asking me to join you this afternoon to talk a little bit about a really exciting area that is moving along very, very quickly. And the reason I was preparing in the airport, Nicole, was that there are new papers coming out and there's Wi-Fi everywhere. So the temptation to see if there's a new one out just is, uncontrollable. So I want to speak to you today about the pros and cons of alternative disinfection technologies for room decontamination. Now, we all have different conflicts in life. I have assumed a new role with Medizone International, who are the maker of one of the products I will talk about, Aseptic Sure. So just so you know, I'm involved with Medizone International. I'm very proud to say so, and Chief Medical Officer of Medizone International, and I'm a shareholder as well. But the objectives of this are to cover the whole range of topics related to these new methods that are trying to take us, I believe the goal is to take us to a new level of environmental safety in healthcare. I hope that you'll be able to describe two of the UV lamp technologies, their characteristics, their efficacy, that you can describe the basis for hydrogen peroxide vapor and mist and their efficacy, that you'll be able to describe how effective ozone-based methods may be as a space disinfection technology, and finally to understand the synergy of combining ozone and hydrogen peroxide as a novel high-level disinfection technology for healthcare spaces and perhaps other applications as well. And I want you particularly to know what to look for when you're evaluating this area of rapidly changing science, both the in vitro, the in vivo, and clinical studies, so that you can make informed choices. So my agenda this afternoon is to talk to you a little bit about the characteristics of the ideal perfect room disinfection system, some of the quality of evidence, talk then about ultraviolet light, hydrogen peroxide, ozone, and then the combination of ozone and hydrogen peroxide producing synergy. I will mention that I am going to be using brand names because the technologies are also specific to the individual manufacturers that it was impossible to describe them accurately and to communicate effectively without using brand names. So I hope you'll forgive me for that. But I think it's very important that we acknowledge the high level of scientific rigor that's been brought to this area by many manufacturers. I'm not going to cover everything. That would be impossible in the time allotted. I'm not going to talk about formaldehyde fogging and aerosolization of surface cleaning agents, chlorine dioxide. I'm not going to be able to do detailed cost estimates of all of the technologies. And most of my data is about bacteria and bacterial spores, so I'll apologize to the viruses and fungi in the room. I may leave you out a little bit. Well, what's the problem? Well, in this room, I don't think I have to spend a lot of time telling you. We have too many healthcare infections, causing needless suffering, mortality, and despite innovations, which are really amazing, and our best efforts, we're still way behind on this. We still have problems with outbreaks of C. difficile, norovirus, VRE, MRSA, etc. The environment, was highlighted by Dr. Starr, is still a reservoir. It plays a different role in different infections. And I believe we need a transformational technology, something that takes us to the new level where we can say to our patients that we can assure their safety, something I don't believe we can do just yet. And just cleaning where the various dots are isn't going to do it, because we're now focusing on where the dots are for auditing using glow germ and other mechanisms, and we need to go way beyond that. So what are the characteristics of an ideal system? Well, it should have the highest possible kill of all relevant organisms, particularly the agent of most concern, Clostridium difficile, because it's spore-forming, because it's common, and because it's deadly. We want something that's fast. Is there anything done better in a hospital slowly? I can't think of anything. It has to be simple to perform. It must be cost-effective. It can be safely deployed. There should be no environmental residues or adverse effects in that regard, as we heard earlier today, and needs to have efficacy to reduce hospital-acquired infections, and it needs to be supported by high-quality scientific evidence. Concerning the evidence, when you're reviewing this literature, it's a challenging area of literature. It's quite mixed, so you have to be highly critical. Peer review literature is what you want to look for. Testimonials and other things that you'll see are interesting and pique your interest, but you really want to rely on good peer-reviewed scientific published literature. In vitro, meaning laboratory-based studies, will often use test chambers, for example, or various environments to simulate reality. Bacteria or other organisms will be placed on a variety of materials. Steel discs or coupons are the standard, but you can see results on fabric, carpet, plastic, a whole variety of finishes that we see in healthcare. You want to see good quality control, exposed, not exposed, growth controls, and that kind of thing, with lots of replicates depending on the way the study is performed. The technology and the techniques going here, we owe a large debt to Dr. Sitar and the CREM group, because they have helped set the standard that has brought rigor to this, but a lot of these new techniques are requiring an adaptation of what's been developed, the QCT or the quantitative care test protocols that the CREM group have promoted throughout the world, give us a lot to work with, though, and are very useful. You do want to see a soil load test, but remember that each organism presents its unique challenges, and so they're not homogeneous by any means. In vivo testing is often done in hospital rooms, laboratories, and a whole variety of field environments. You'd like to see random assignment of hospital rooms where possible. You'd like to see no overlap of methods, that if you're comparing two methods, that you don't use one and then follow up with the other. You have to give kind of a washout period, if you will. You want to see detailed surface culturing protocols, and that's an art and a science unto itself. Just rubbing a swab on a table, it may sound simple, but it's actually quite complex science unto itself. You want to see a good protocol that's highly controlled, highly standardized, and there are many different methods. You want to see another technique that I look for is to see that the testing involves various small discs of material, often stainless steel, that are loaded with organisms like MRSA and C. difficile spores that are also placed in the room as sort of an ultimate control. And you, particularly as was highlighted earlier today, you don't want to be using the vegetative form of spore-forming organisms. You want to use the spores. In interpreting the results, what I look for is I want to see the expression of the data as a log 10 kill or the log 10 of the survivor. Remember, with bacteria, we're talking about huge numbers. It's in logarithms. If you didn't do logarithms in grade 12, you've got a problem with this data right off. So get a good calculator or get somebody to help you work through that. Kill is really what you started with minus what you killed, or what survived, rather. That's the kill rate. But it's done in a logarithmic way. Ideally, any mean should be geometric means, particularly if there's a large amount of data. They need many, many replicates. Depends on the study design. But 3 or 4 or 5 or 6 replicates is interesting and valuable, but it's only a starter. Surface swabs, again, are typically expressed as the number of organisms per square centimeter. Typically, it's in the tens to hundreds. If you see only 1 or 2, it's quite low. If you see thousands and thousands, it's pretty dirty. And that's a little out of the ordinary. You can either count specific pathogens, the number of C. diff spores, the number of VRE, the number of MRSA, or a total heterotropic colony count or aerobic colony count, telling just all the bacteria on the surface, pathogen or not, giving you an idea of how the system performed. Clinical studies are few and far in between. There's a few tantalizing ones that we're getting better at this, and that's where I'm very excited because I think that's where we're going to go. Before and after studies will be common. We did a technique and the results before and after were this and this. But everybody knows that our hospital-acquired infection rates vary over time. So you have to be exquisitely careful, and that's where really we do need to see randomization and good controls. So be cautious with the before and after. Again, they're informative, they're interesting, but they're not definitive. So we'd like to see randomized trials. They're difficult to do, they're costly, just like with medication, randomized controlled trials. And often they will be combined with those little discs put in selected spaces, lacing the room with loaded coupons, as well as looking at clinical outcomes over time in a randomized fashion is the ideal. I don't think we're there yet. So let's talk about the first area of technology, and that's specifically ultraviolet light. Ultraviolet germicidal irradiation is really ultraviolet lights used in different facilities. UVA, B, and C you've heard about. They're part of the spectrum of short wavelength of light. UVC between 280 and 200 nanometers has the most antimicrobial effect. It basically damages the DNA of the organism. And there's a quiet worry, well, maybe it doesn't damage it enough. It doesn't kill it, just allows it to help mutate or something. That's always a theoretical risk. 265 nanometers is felt to be the optimal wavelength. And susceptibility to ultraviolet light by organism is quite variable, surprisingly. So you can't take it for granted. It also depends upon the conditions in which it's applied. It's most commonly been used inside air ducts, for example, where the airflow, the temperature, any water flow rates, and surface reflectivity are all very important. And obviously, distance is key. The design of UV light systems is not as standardized as it could be, and there's no consensus guideline for some of the design aspects, so we have to be cautious in knowing that. And you can see this chart here from the ASHRAE journal just gives you an idea of the susceptibility of organisms to UVC, and it's quite similar to the classic Spalding classification of susceptibility, where vegetative bacteria are the most susceptible, and fungal spores in this case are the least susceptible. Now, you can generate ultraviolet light with two kinds of bulbs that are generally available. A mercury vapor lamp, which creates specifically narrow spectrum in the UVC range, quite specifically 253.7 nanometers. It's close to the peak at around 260, 265 that causes optimal DNA damage. And it's a continuous form of light exposure. The other type of bulb is a xenon vapor lamp that has xenon that's pulsed. So there's a bright flash of light that's incredibly bright. It's in milliseconds, producing a spectrum of light that's quite broad over UVA, B, and C. So you get more spectrum, but it includes the most potent wavelength of around 260. The high intensity of the fast pulses gives pulsed xenon light perhaps better efficiency in some people's mind, but the data is still not out on that. So here's one of the units marketed by Lumalier. It's called the Tru-D unit, and it is, as you can see, a bank of lights and it has a shroud that you can put over it when it's not in use. It's wheeled, you can move it around, and you immediately see, oh, we can move this around in an organization. Some work on this, it's automated. It's been shown to produce about a 3-log kill of vegetative bacteria, MRSA viri and Acinetobacter baumannii, and about a 2.5-log kill of Clostridium difficile seeded onto Formica surfaces that work done by Rutala et al. The Tru-D system has also been studied with environmental contamination with vegetative bacteria by Dr. John Boyce, who's done a number of these studies, and they measured the aerobic colony counts and C. difficile inoculated, again, onto the stainless steel discs that I've talked to you about. Room decontamination then with the Tru-D UV system resulted in a mean C. diff reduction of around 1.8 to 2.9 logs, with cycle times of around 34 minutes up to 100 minutes were used. The surfaces that are in the direct line of sight were significantly more likely to yield negative cultures after UV decontamination than before decontamination, meaning that those that are not in the line of sight are an issue, and there's often the need to reposition the unit, for example, in the bathroom, or as you know, many hospital rooms are not square, right? So there can be issues with line of sight. Using inoculated surfaces, Nirzanik published in BMC Infectious Diseases last year, using a reflective dose as they measured at 22,000 microwatt seconds per centimeter squared over a 45-minute exposure. The kill of C. diff spores and MRSA was around 2 to 3 logs, and the kill of viri was 3 or 4 logs. They had the same level of kill and of MRSA and VRE with a 20-minute exposure. They reduced the exposure. However, they found that the C. diff spore kill was minimized significantly by a 20-minute exposure. So time is an important variable, as is the distance. So you can see their results here graphically. They used a number of C. difficile strains, spores, which is good. And you see the best was about 3 logs, lowest at about 2 logs. For MRSA, around 3 logs, and for VRE, between 3 and almost 4.5 log kill. This, they further then looked at, presented graphically to talk at the proportion of kill, and you can see, if you see this data in the graph, you go, C. diff, that went way down, MRSA went way down, VRE went to 0, this sounds good. But I did a little back of the envelope calculation for you. How much surface area is there in an average 2 meter by 2 meter bathroom? And if you think of that 1 meter swath of the middle of the room on the wall level where the sink would be and where the toilet might be, where you might touch, that's actually 60,000 square centimeters. And so if you look at their before and after calculations of their results, that means you'd have on that kind of surface area 600 C. difficile spores reduced to 24. Hence my question earlier, well, what is the infectious dose of C. diff? It's, of course, hosts susceptibility driven, but that's enough to cause disease. MRSA likewise goes from 1,200 to say 240 MRSA bacteria on that surface area, and VRE in this case probably may have gone to 0. But it just reminds us that how low do we need to be, and what is our goal here? What are we trying to achieve, and what level of protection is necessary? The other player in this market is Xenex, and they have a pulsed xenon light system. There's a different number of configurations. This is one of them. And this is their own internal data presented in an abstract, so I back calculated a little bit, so I believe we've got this right. But their exposures are 8 to 12 minutes per exposure, which seems very favorable. For MRSA, that results in about, even at 8 minutes, a 5 log reduction, which is impressive. For VRE, about a 4 log reduction, and for C. difficile, somewhere between 4 and 5. And if you boost it to 12 minutes, you get a better C. diff kill. What I note, however, is the distance to the lamp was 1 meter for C. difficile. Very, very close. So there's no distance data to tell you what happens, 3, 4, and 5 meters. And their number of samples is quite small. And so I think that this needs, more published peer-reviewed evidence. This is from an abstract only. There's a published report in ICHI by Stibich et al. At the MD Anderson Cancer Center in Houston, Texas, between January and March in 2010. They had 12 rooms that they extensively cultured at discharge, particularly looking for VRE, which was an issue for them. They did a typical isolation clean with their, I think it was a quaternary ammonium chloride, a germicidal agent, with a 30-minute clean per room, sounds about right. And then they did 3 by 4 minute pulsed exposures to the Xenon, the Xenex lamp. And the cultures were taken before the cleaning, and then after the cleaning, and then after using the Xenex lamp to see what the incremental benefits were. You can see here, interestingly, the colony-forming units as 33, 27, and down that middle column. Before cleaning, it was around 33 colony-forming units, the heterotrophic bacteria count, total bacteria, 33 per square centimeter. Well, that's in the range. That makes sense. After standard cleaning, it only goes down to 27, though. That's a bit of a worry, barely statistically significant as it turns out. And again, comparison number 2 is before cleaning, same number, 33. After the pulsed xenon light, it goes down to 1.2, which is interesting. It's about 75 samples. And comparison number 3 was after the terminal clean, which didn't have much of an effect anyway. It did also bring it down to the level of about 1 CFU per square centimeter. So this is interesting and intriguing data. A Cooley Dickinson Hospital is a 140-bed hospital in Northampton, Massachusetts, that also applied this technology between January and September and published this at the IDSA meeting in last year. And it's an uncontrolled observational study. They used 2 by 7 minute pulses in the room and 1 by 7 minute pulse in the bathroom. That's around 21 minutes, plus the time to move things around. Their aim here was to deal with C. difficile, which was a problem at that time. They pre-cleaned all the rooms with a standard operating procedure that included chlorine bleach. That wasn't a change, so they were consistent. And their CDI rates is what they measured, and in 2010 they went from 0.95 per thousand patient days, and 2008 to 2010, the first 3 quarters combined was 0.98, so there's some consistency there. And during 2011, after doing this, it went down to 0.32, which is a significant drop. They also note in the bar graph, you can see they had no deaths and no colectomies during the first 3 quarters of 2001. Again, interesting and intriguing data, certainly worth following up on. Difficult to draw firm conclusions. But what can we conclude then about the state of UV lights? Well, this is my summary. There's the Mercury bulbs and Xenon bulbs are the 2 types. They have an exposure time between 20 and 100 minutes for the UVC lights, and pulses that range between 8 and 12 minutes per pulse, but you need several pulses in a room depending on the line of sight with the Xenon bulbs. Vegetative bacterial kill is in the 3 to 4 to 5 log reduction. And the C. diff spore kill rate for the UVC lights is around 2 to 3 log, not that high, and about 4 to 5 log, but very limited data. I would be cautious in over-interpreting that. Risks are, with the system of the UV exposure, you can't be in the room, obviously, and toxic byproducts with the mercury lights is the concern about mercury itself. That does not appear to be an issue with the xenon-based lights. And the UVC, there are some clinical trials that have been done, although they're limited, showing some efficacy and reduction in infections. And I'm going to show you even a head-to-head comparison with hydrogen peroxide in a minute, but none on the xenon that I was able to see. I don't believe the studies that were presented in abstract really constitute that yet. Costs are difficult to come by. They aren't on the websites, if you've noticed when you look. But I was able to determine a quotation from one author talked about the UVC light system, Tru-D, around $120,000 list cost. Obviously, prices vary depending on how many you buy, and about $1,600 to replace all the lamps, but they last for 9,000 hours. Could not get any data on the pulsed xenon system at all. If anybody knows, I'd love to know. The line of sight effect, I think, is a significant issue, and the scanty data on the xenon light system is still a bit of a concern. Anybody know what that object is? Remember good old Lister, who would spray carbolic acid all over the place? That's one of his units. And not that that's what we're using these days, but it raises a similar idea, and that's hydrogen peroxide technologies, of which there are 3 and a growing body of evidence that's quite intriguing. Bioquell makes a system that uses 30% hydrogen peroxide as a vapor. Glossair, by Advanced Sterilization Products of J&J, uses a 6% hydrogen peroxide to create a mist and aerosol, and VHP by Steris, vaporized hydrogen peroxide, produces a vapor using a 35% hydrogen peroxide solution as well. Just a few pictures of the instrumentation taken from the industry websites. Here's the Steris VHP 1000 ED item, or system, the Bioquell Q10, and the Glossair systems, the 600 and the 400 models. The Steris system, the VHP activity against the typical spores of Geobacillus and others is quite profound. I mean, it has a 5 to 6 log reduction in the laboratory setting. Didn't see any data regarding C. difficile, of course, against this organism. All of these systems require some care to close air ducts, or at least shut them down and cover them up. I've had some experience in doing that. It's not as difficult as it looks. There's many very slick products from the abatement science that allows you to do it quite quickly and not destroy the environment when you're pulling it back. So there's some very good products that let you do that quickly and easily. The efficiency for Clostridium difficile is most well known for the Bioquell system. One study by John Boyce looked at 5 high incidence C. difficile wards, and then followed by hospital-wide decontamination of rooms after all patients with C. difficile. And they had a 25.6% of the cultures from surfaces before hydrogen peroxide vapor in the room were contaminated with C. difficile. 25% of the rooms had C. difficile in them on discharge. That's very high, compared to 0 after the hydrogen peroxide vapor decontamination procedure, which is very notable. During the 9-month intervention period on these high incident wards, the rates of C. difficile dropped from 2.2 per thousand, fairly high rate, down to 1.28 per thousand, which was statistically significant, didn't eliminate it entirely. And their hospital-wide incidence went from 1.89 to 0.88 per thousand patient days during the high incident month periods, pre and post intervention. Again, very interesting. Not randomized, not multi-center, but still notable. With respect to MRSA and the Bioquell system, 75% of about 350 swabs taken by French et al. Before cleaning yielded MRSA, 75%. That's very high. After cleaning, all of the areas remained contaminated, with 66% of the swabs still yielding MRSA. After treatment of 6 rooms with the hydrogen peroxide vapor Bioquell system, only 1 of 85, but it's a smaller sample size now, showed MRSA about 1.2%. Their cycle time was 5 hours, fairly lengthy. And just to note that it generates hydrogen peroxide in the range of 500 parts per million. Anything over 1 part per million would be toxic over 8 hours, according to EPA standards. But they got excellent results in eradicating MRSA, very high level of MRSA. Just so that you're aware, you will find literature referring to the Sterinis system out of France. It was purchased by J&J and is part of the line of products offered by Advanced Sterilization Products, is now known as Gloss Air, so that you understand the names. And an interesting study done in Turkey by Dr. Piskin, they looked at steel discs inoculated and placed into many locations into a standard hospital room of 53 cubic meters, which is about right, a small single room. These steel discs are strategically placed, loaded with the organism of choice, and you can see that they had a 2.5-hour cycle time, and after applying the Sterinis mist, and you can see in the table the comparison of the bacterial load before and after. So what they did is they had them on discs, and they had them sitting in a petri dish, and sometimes they put the lid on, and sometimes they took the lid off, and in other ones they had an organic soil, and other ones they didn't. And what you can see is that they had a 4-log reduction in MRSA and Acinetobacter before, and once they put the lids on, there was a slight reduction down to 3-log, 3.5-log. But when you combine soil and putting the lid on, you really reduce the efficacy of the system. So organic soil, we know, we've been taught by many that is important. And obviously, though, when combined with a lack of access of the substance, really reduces its efficacy to some extent. Barbet out of Paris did a very interesting study looking at hydrogen peroxide, again, the Sterinis system versus bleach cleaning. And they started off in vitro looking at a comparison on polyvinyl chloride samples and laminate samples, cleaning with 0.5 sodium hypochlorite and hydrogen peroxide with the Sterinis system. And you can see that the log kill was roughly equivalent of around 4 log kill for both, with a 10-minute application of the 0.5% bleach. Interestingly, though, and I don't know if I can explain this, when they put this into the live application in patient rooms for C. difficile terminal cleaning, the 0.5% bleach at 10 minutes, over 16 rooms, 24% down to 12% contamination. So it performed less well. Now, what was the cleaning like? There's all those questions that are coming up in our minds. But the Sterinis system, presumably in the same rooms, had a 19% pre-contamination rate, went down to 2% after use of the Sterinis system based on cultures. So it seemed to perform better in that setting, which is very interesting. This is an interesting paper published just in May by Havel and others, and they looked at a 500, this is kind of a head-to-head, and we all like those kind of studies, you know, who's going to win out. Tru-D versus, which is the ultraviolet light UVC system, versus Bioquell, 500-bed hospital, 15 patient rooms selected at more or less random over 8 wards, looked at 5 high-touch surfaces, all the ones that you would think were important. They looked at the aerobic colony counts on those surfaces, how many bacteria hanging on there, and they loaded steel discs into those selected areas as well with 1 million, 10 to the 6th, C. difficile spores placed in those high-touch areas. And they also went one further. They took biological indicators with 10 to the 4 or 10 to the 6 Geobacillus steatothermophilus, which is sort of the ultimate hard spore former to kill. Results were very informative. Hydrogen peroxide Bioquell, 93% of the cultures became negative from the surface. They had a 6-log C. difficile kill, which is consistent with other findings. And they killed all of the BIs except, I think, for one, so it was very effective. Their cycle time was 2.5 to 3 hours. With the Tru-D UVC system, again, only a 50% kill rate of the bacteria on those surfaces, less than a 2-log C. difficile kill, and not very great results with the biological indicator with a turnaround time or cycle time of 0.5 to 1.7 hours. Very interesting. You can see here the rapid MRSA regrowth that can occur, and that's a worry. What happens after you decontaminate a space? Will stuff regrow? Looking at the comparison of the hydrogen peroxide systems, therefore, let's compare what we know between Glossair, the Steris VHP system, and Bioquell. They use different products and different concentrations of hydrogen peroxide. The Steris and the Bioquell systems are a vapor, a gas phase, whereas the Glossair is more a dry mist aerosol phase. The concentrations achieved of hydrogen peroxide are substantially different. The cycle times are in hours, 2 to 3 to 8, depending on the circumstances. The log kill of C. difficile with the dry mist protocol is 2 to 3 logs. I couldn't find very much published data for the Steris VHP system, to be honest, for C. difficile, but their bacillus kill is very high, so you would assume that it would be the same for C. difficile. And a 6-log kill for C. difficile and bacillus by the Bioquell, which is the most established literature. Control trials, very little under the first two. Bioquell, is, because it's been around longer, has got a higher level of data supporting its efficacy. You can see the cost again. I understand that the cost for the Glossair system is in the $60,000 range, about $50 a room to treat. I could find no data regarding the VHP Steris system. For Bioquell, again, comparable capital cost around $44,000, but I wasn't able to find data on the actual room treatment costs. But what about ozone? Ozone's been around a long time. It's been experimented with back in the 1800s. It was demonstrated that diluted ozonized air could sterilize polluted water. And ozone has a molecular weight of about 48. It's a highly reactive species with a high level of energy. It's a very energetic molecule that likes to extract electrons from other molecules in the neighborhood and releasing one of its own oxygens in the process. This is Canadian work from Sharma and Hudson in British Columbia, looking at pure ozone as an antibacterial, and they document bacterial kill rates that I think are pretty modest, 3 to 4 log bacterial rate across, including C. difficile in their hands, noting that high humidity, over 80%, in the 80 to 90%, was an essential ingredient. Ozone, generating that level of ozone, however, has proven difficult. You need a lot of electricity. It takes a long time and so forth. So by itself is quite limited in its application in this regard. However, I'm going to speak to you a little bit about the work that I've been involved with my friends at Medizone International and at Queen's University, where we have discovered, reminding ourselves that when antibodies attach to bacteria or viruses, they generate a minute amount of ozone and a little bit of hydrogen peroxide. Now, nature never would waste that opportunity, wouldn't do it for nothing. And Levy et al. Have shown in the Scripps Research Institute in Oxford that what the byproduct of that is the combination of ozone and hydrogen peroxide combined to create a new molecule. That new molecule is trioxidane, or H2O3. It is incredibly reactive, and it is very lethal to microorganisms, even in the most minute. No one knows how low. Very short-lived molecule, but very potent. So the experiments that we set out were to determine the antimicrobial effects of this combination with ozone and hydrogen peroxide, taking aim at healthcare and foodborne pathogens, and to document the extent of the synergy in full-sized rooms. So again, hydrogen peroxide used alone. In our hands, we got very low bacterial kill, one log, 2 logs at best, certainly not sporicidal. Ozone by itself, again, we got 30 to 200 parts per million, again, a low level of bacterial kill. And if we cranked it up to 800 parts per million, sure, you could get the kill, but it was challenging. And what we've discovered is the synergy of ozone and hydrogen peroxide creating H2O3 really results in a dramatic increase in bacterial kill, the exact magnitude of which I can't quantify for you. Our tests follow the QCT2 standard methods by Satara, all adopted to using an aerosolized system, obviously, but we've, as closely as we could, we follow those, and I thank him for sharing that with me. And, you know, we got pretty interesting results. We started off with a polycarbonate chamber, fully instrumented to measure all of the conditions, used MRSA as our test organism on stainless steel discs placed in the chamber. We then upscaled, when we got excellent results, to an in vivo system. This machine we lovingly call in the lab Frankenstein. It uses a corona discharge. We're now using ultraviolet light generators to create ozone. But the room was fully instrumented. We knew all of the gas levels and ozone levels in different areas. We had scrubbers to get rid of the gas, and hydrogen peroxide vapor was generated, and test discs placed strategically with the target organisms in various areas of this room that was cordoned off. We've used different rooms in different locations, even in local hospitals, and get the same results over and over again. So Frankenstein was replaced by Woody, which had a wooden frame, and it was a smaller, more compact unit. It too worked very efficiently, and led to the design of one that was hopefully will be, well, is being commercialized. So here are the results that we've seen in combining ozone and hydrogen peroxide with the technique known as aseptic sure. You can see that the ozone level that seems to be optimal is 80 parts per million, the hydrogen peroxide at 1%, and the exposure times are quite brief, about 15 minutes for MRSA, viri, E. coli, Pseudomonas, Salmonella, Listeria. Between 15 and 30 minutes being preferred for assured spore kill for C. difficile and Bacillus subtilis, and recently Mycobacterium tertiae. In all of these cases, we have achieved 6-log kill consistently over and over and over again, and it's quite robust. We've moved the system across different organizations and different settings, different rooms, and it works quite well. We've also learned that using the aseptic sure system on stainless steel, we've used plastic from toilet seats, laminates, carpeting of a variety of types, cotton synthetic cloths. The cotton cloth is from the room curtains that someone donated, and with and without organic soil load. So we're very excited about this because it's really the first demonstration of a combination of techniques using ozone and hydrogen peroxide together with a very significant synergy. It's very fast. It takes about 20 minutes to ramp up the room. The exposure times are, as I showed you, and about 20 minutes to bring it back down, depending obviously on the size of the room. Very broad spectrum, and the gas, of course, penetrates, and you don't have line of sight issues. The approximate estimated cost for the instrumentation will be in the $90,000 range, and about $10 to $20 to treat a room, depending on the size. We've published this, if you want to look it up, in the American Journal of Infection Control. I think it was published in December issue, and you can see those results, and we'll be having more coming along. This is the new unit known as Buzz in the lab after Woody, and this is Kelly, our technologist, and it's a pretty blue color, and it's very mobile. It's remote controlled, and the two white things you can see next to it are scrubbers that decompose the gas, and you're left with really no residual other than oxygen and water. And oh, by the way, we had to do this. We went to the local public health lab. You got any bed bugs? Somebody opened a drawer and had a pill bottle full of, guess what, bed bugs. So we couldn't resist the temptation to put them in the chamber. Now, I'm not an entomologist, so we got a collaboration going with professional entomologists from the University of Purdue with 100% kill of bed bugs, including very hardy eggs. They're hardier than spores, it appears, and requires much higher concentrations of ozone at 180 and 3% hydrogen peroxide and a 24-hour exposure. But most of the methods that are going to kill them all need something like that. So it's very interesting findings that we're going to continue to work on. So what's the characteristics of an ideal room disinfection system? The highest possible kill of all relevant organisms. Again, it's highly variable with the light systems. It's highly variable with the hydrogen peroxide, although Bioquell is a well-established high-level kill. The aseptic sure combination of hydrogen peroxide and ozone, likewise, likewise very fast for the combination system, probably because of the synergy, although the Xenon pulse light is very intriguing with the rapid turnaround time. It has to be cost effective and safely deployable, although there's closing events and things, that's fairly straightforward. There are no environmental residues with any of these methods that I know of, although after this morning's lecture, I think we have to be always on the lookout for that. And we do need data now to show the reduced incidence of healthcare infections, and all of the manufacturers are working that, including Medizone, looking at clinical studies. And we really have to rely on high quality published evidence to guide us in this area. So I hope the final result is very clean environment that we can all dance in. When you've used ozone and hydrogen peroxide, the room smells like a fresh spring day after an electrical storm. So it has that. That's of course ozone that you smell. So thank you very much.
Thank you, Dr. Zoutman. We do have time for a couple of questions if anybody has any questions.
Zoutman. Hi, Dr. Zoutman. I'm Verusha. I'm from Qatar. And in my facility, well, we've tested loads because we are trying to get the highest technology, obviously, available in our facility. But if I look at my microbiology, I always find that it reminds me of a horror movie because there's always some pathogen or bacteria that gets away, right?
Yeah.
And with all these development and research that we do in developing new technology to fight bacteria, don't you think we open up a new field of causing more harm for the human at the end of the day? Because what would be the effect be of your product in the long run on the human?
Well, we obviously don't know that yet. Yes. We have no evidence at this time that we know that the ozone levels after we're done, because it can be measured fairly readily with handheld meters and very sophisticated instrumentation that we use, the amount of ozone is gone, it's zero. And we bring it back down way below EPA standard, which are 0.01 ppm over an 8-hour exposure, goes way below that. We also know that we can bring the hydrogen peroxide levels down, and the outcome of the reaction is oxygen and water. So as far as we know, but we always have to keep an open mind, you're right to point that out, as to other unintended consequences of any new technology. And we're going to continue to do that. But so far as we know, there are no toxic effects. Obviously, you can't be in the room when this is happening. That's obvious.
Doctor, I saw the article, the head-to-head comparison of the Tru-D and the Bioquell, and one of the things that struck me is afterward, Tru-D had a whole slew of PR releases talking about one finding, which was that the Tru-D, the study, a soundbite, that the Tru-D was easier, thereby making it more practical.
Yeah.
And I was wondering if you could comment further within the confines of environmental services and the reality of a hospital, the skill level, the time it takes, the training required, and so on, of these technologies on the fly today, yeah, which one would you recommend?
That's a very good and difficult question. The ultraviolet light is appealing because you can park it and turn it on and get everybody out of the room. However, line of sight issues will be important, and so I think that will have to be contended with, and distance and other exposure issues. This is where the clinical trials are going to be necessary, and human time motion studies. The other systems that use a vapor or a gas, hydrogen peroxide ozone combinations, can be done by either qualified technicians who are trained, who you bring in, or you can train your own people to do it, and these systems have enough safety, defaults and safety checks and balances that, for example, door lockouts and that kind of thing, that they can be done very safely and turned around. There's a paper, I think by Dr. Boyce et al., that looking at Bioquell said that they were able to bring it into the flow of a busy hospital where he works, and I was very happy to see that paper. And I think we're going to need to apply modern lean methods to get that down to the minimum time possible. And we're on a push at Medizone to see if we can get this, how fast can we get this to work. We think we're optimized at this point, but we're continuing to work on that.
Hello, I'm Deborah from Toronto Public Health, and I was particularly interested in the piece about the bed bugs, because we do have a bed bug team that has been working hard to deal with this issue in Toronto Community Housing and the shelter as well. And I'm just wondering if there'll be any testing, particularly in shelters or...
Well, let's talk.
Okay. Thank you.
Yeah, let's talk.
Thank you so much. Again, an excellent presentation, and thank you for doing this for us.